everyone. I'm so glad you tuned in today. Today, we're going to have a special show. We're going to talk to Dr. Eric Morgenstern. He is a gastroenterologist. What's a gastroenterologist? It's someone who deals with the digestive system. Yes, when we get older, we are doing things that we always do, and we don't think anything of it. We don't think they're warning signs or anything like that. We've been belching all our lives, and we don't think anything of it. It's just what we do. But he's here to let you know that there may be something more to it. So please make sure you take notes and you listen and comment, but also share, because if you don't need the information, somebody else may. Okay, here we go. Autumn is here. Hello, everybody. Welcome to my show. This is Francine. I'm your host. Welcome to Autumn is Here. Today, we have a special guest. Today, we have Dr. Eric Morgenstern. He is a gastroenterologist, and we're happy to have him here today. Welcome to the show.
Thank you very much, Francine. Appreciate you having me.
Well, thank you for taking the time out. As you know, my show is about getting people more involved with their aging parents and getting caregivers some information, and also getting some seniors some information. So first, before we get started, tell me a little bit about yourself.
So as you mentioned, I'm a gastroenterologist in private practice in New York City. Been in practice for over 30 years. And for those people listening who aren't aware of what gastroenterologists do, we're involved in the gastrointestinal tract, esophagus, stomach, intestines, both small and large intestines. Some of us do some work with liver and pancreas, but it's taking care of the digestive tract. I have a interest in both inflammatory bowel disease as well as colorectal cancer screening. So I spend a lot of my time doing colonoscopies and endoscopies, specifically screening for colorectal cancer, which I'm sure we'll touch on at some point. When you told me about Autumn's Here, it definitely struck a chord with me, because I think I'm qualified on two levels here to join you today. One is as a physician, as a gastroenterologist, to get the word out about what's important as far as people age. But I'm also the child of two parents who passed away with both long-standing chronic illnesses, and went through that as a caregiver, organizing care and taking care of them from a distance. So I can relate to the hurdles and obstacles that come with caring for elderly parents.
Yes. Oh, wow. Okay. Well, great. I'm glad that you are here today to give us insight on both ends. So what are the things as people get older that they should look for that may happen in their digestive system?
So we should probably begin that with focusing on lower gastrointestinal problems, problems in the colon, because that's one of the major issues that people will have as they get older. And from a symptom point of view, but not only that, from a screening preventative type of point of view. So colorectal cancer, cancer of the colon, cancer of the rectum, is the third most common cause of cancer death in both men and women. In women, it's behind lung and breast. In men, it's behind lung and prostate. So if you take both sexes together, it's the second most common cause of cancer death in the United States, behind lung. It does have some risk factors, which we'll get into shortly, but colorectal cancer screening for people who are average risk, meaning they don't have a history of cancer, the colorectal cancer themselves, don't have a history of polyps, and don't have a family history of colorectal cancer, should start at the age of 45. And then based on what that first screening procedure it finds, should then continue with a set interval that the doctor would discuss with you. So certainly, by the time people are seniors, you could define that as 65 and older, they should have already well started screening for colorectal cancer. How long that continues into somebody's, lifetime is really dependent upon what's found, as otherwise, and also their otherwise general health. But these are all things that people should freely discuss with their doctor, whether it's their internist or their gastroenterologist that they were referred to. So colorectal cancer screening should be on everybody's radar at some point. Nobody should die of colorectal cancer at this point in medical care. Secondly, are changes in bowel habits, which a lot of people, as they age, experience constipation being much more common. And it's a common myth that people feel that constipation is part of the normal aging process. It's not. It's not. There's just a number of different physiological things that may occur over time as people age that can lead to constipation. Inactivity is one of the biggest. So remaining active is extremely important in bowel health. Fluid intake, extremely important. As people age, men start to restrict fluids because they have prostate issues and they don't like running to the bathroom all the time. And women develop bladder irritability and bladder sensitivity as they age. And they also very often start to restrict fluids. So proper fluid intake is extremely important. Dietary factors are important, fiber being the most important factor there. And then as people get older, they're very often on medications, whether it's for high blood pressure, for thyroid disease, cholesterol. And these medications sometimes do have side effects. Constipation is not all that uncommon from certain medications. So what I'm getting at here is the long and the short of it is constipation is not a normal part of the aging process and shouldn't be accepted as something that is natural and should occur. It should be looked at and it should be appropriately treated and taken care of.
Okay. So with colon cancer, the causes, like, is it because of your family history? Is it because of what you're eating? Is it just a natural thing that happens after time? And if you're not getting checked out?
So it's certainly not a natural thing that's going to happen over time. Nobody should assume they're going to develop colorectal cancer if they live long enough. This is a common question I get, usually after a colonoscopy. What can I do to decrease my risk and manage it? Some people will ask even before the procedure. So it's an excellent question. I like to group things into 3 buckets when I talk about what causes colorectal cancer. And a good word of advice, not only about this, but about medical issues in general. Worry about the things that you can control. If you have no control over something, worrying about it's not going to make a difference. So the things that you have control over with colorectal cancer, we partially touched on, and those are dietary factors. There's a clear association with polyp formation and colorectal cancer with diets that are low in fiber and high in animal fat. So therefore, you want a diet that is high in unprocessed fiber and low in animal fat. And by unprocessed fiber, we're talking about grains, bran, wheat. We're talking about green leafy vegetables, fruits and vegetables with waxy coats. And a good baseline for women is about 25 grams of unprocessed fiber a day. You should start reading, dietary labels. And for men, it's about 30 grams of unprocessed fiber a day. And be careful with that. More is not better. Excess dietary fiber can cause gas, bloating, cramping, distension, and make you feel uncomfortable. So that 25 for women, 35 for men grams a day is a good general recommendation. Other risk factors for colorectal cancer, cigarette smoking. I tell patients if they don't smoke, not a good time to start. And I work, hard with patients to get them to stop smoking, obviously for all the other reasons as well. Colorectal cancer not being the least. And then type 2 diabetes and obesity are both risk factors for colorectal cancer. So these are things that people very often do have control over, specifically with dietary factors and exercise factors. Those are the major risk factors for colorectal cancer that you have control over, the environmental factors. The other two buckets I referred to, you don't have control over. One is your family history. And in 2025, we don't have the ability to alter our family history genetically. It is what it is. So you're dealt those cards and you got to play them. And if there's a family history, specifically in first degree relatives of colorectal cancer or certain types of polyps, you should start that screening process earlier. And the third bucket is bad luck. And obviously, bad things happen to good people and you can't control your luck. So that environmental bucket is where you really should focus your time and energy on when it comes to colorectal cancer.
Okay. So let's talk about some other digestive issues. A lot of people, when they get old, talk about acid reflux and things like that. Please explain a little bit about that.
Sure. So acid reflux, the medical terminology is gastroesophageal reflux disease, or GERD, is extremely common. And I spend a good portion of my day treating patients for gastroesophageal reflux disease. That's the disease. The syndrome, the symptoms of gastroesophageal reflux disease are varied. By far and away, the most common is heartburn. So many people use that term interchangeably. But again, heartburn is a symptom of GERD. It's not a disease of itself. And people can have gastroesophageal reflux disease without having heartburn. Heartburn is a burning sensation behind the breastbone, usually in a to and fro manner. And that maneuver I just made with my hand up and down is called the universal heartburn sign. When patients make that sign, they talk about heartburn. But again, heartburn is not the only symptom. A chronic cough, a chronic sore throat, chronic sinusitis, periodontal disease, dental enamel problems, nocturnal asthma can also be symptoms of gastroesophageal reflux disease. So you need to take those into consideration if the routine maneuvers to treat those symptoms are improving. So gastroesophageal reflux disease, like I said, is common. It can very often be treated, again, with dietary, behavioral, and lifestyle changes. So there are certain foods and products that are clearly associated with reflux disease. Red tomato-based sauces, citrus juices and citrus fruits, mints, chocolate, fried foods, fatty foods, carbonated beverages, alcohol, tobacco, caffeine are the big simulators for gastroesophageal reflux disease. And if you're suffering from symptoms of reflux, those should really be ideally eliminated, but certainly reduced. Small, frequent meals are going to also be very effective in treating reflux disease, not necessarily restricting calories if you're in an ideal weight, but just spreading those calories out to 4 or 5 meals as opposed to 3 larger meals a day. And then most importantly is not eating late at night. Giving yourself at least 3 hours after you eat before you lay down. You don't have to stand up, you can sit down. But reclining or laying down within 3 hours after you eat takes away the benefit of gravity, and you're more prone to suffer from gastroesophageal reflux disease. So initially, we work on behavioral, dietary, and lifestyle recommendations like we just talked about. Obesity is also a factor there. Tight-fitting clothing is a risk factor there. So we try to work with people with, those types of issues. And if we can get them to treat their reflux disease without medication, that's great. Otherwise, we typically give a trial of an acid-suppressing medication. And if we get results there, we then try to remove the acid-suppressing medication and see how they can do without it. If we can't get that under control, very often it does require a test called an upper endoscopy, where with a flexible instrument while the patient is sedated, we take a look at the esophagus and stomach to make sure that we're dealing with just reflux disease and nothing more serious. Now, if you have gastroesophageal reflux disease symptoms with what we call alarm symptoms associated with it, that's a different story, and that should be evaluated immediately with an upper endoscopy. And those alarm symptoms would include difficulty swallowing, where you feel food getting stuck either in the throat or mid-chest or lower chest. Vomiting blood would obviously be an alarm symptom. Or anemia could be an alarm symptom as well. So those symptoms need to be evaluated at different intensity than garden variety reflux disease, which we try to manage with behavior, lifestyle, diet, and medication before we get more invasive in our evaluation.
Well, and left untreated, what does it lead to?
Excellent question. So first of all, discomfort. It's not fun to have heartburn or chronic cough after you eat. So that's a biggie, and that's usually a driving force. When patients have symptoms, they're usually a whole lot more likely to be amenable to evaluation. But longstanding reflux disease that goes untreated can lead to chronic inflammation of the esophagus. That can lead to ulcer formation, which can bleed. It can lead to strictures or fibrosis or narrowing of the esophagus, where you eventually can get food caught up and stuck. And then the most concerning untreated long-term effect of reflux disease is something called Barrett's esophagus, where the esophagus tries to change its cell type in an attempt to protect itself and behave more like an intestinal cell. That sounds adaptive, but the problem with that is that when you change your cell type, you're monkeying around with the cellular DNA, and that is the first step in a sequence that can lead to cancer of the esophagus. And cancer of the esophagus in this country is one of the fastest growing cancers related to reflux disease.
Okay. From experience with different people and friends and stuff like that, they seem to think don't take it as serious because they seem to think that if you take Tums or something over the counter, that will take care of the acid reflux, and then they end up taking a lot of that, and but somehow when you take a lot of that, that hurts you in another way. So can you speak to that?
So you mentioned over-the-counter remedies for reflux disease. Tums is certainly one of the more common ones. Tums is calcium bicarbonate. The bicarbonate component of that neutralizes the acid. So you're treating symptoms. It'll take away the burn for a short period of time that you may have in the chest, but you're not treating the primary problem. And the calcium component of that, which is just a vehicle to get the bicarbonate into the system, is constipating. So if you take enough Tums, enough calcium, I can pretty much assure you you're going to have problems with your bowels at some point during that. Some of the other treatments, like over-the-counter antacids, Matalox, Mylanta, Gaviscon, they are magnesium-containing antacids. Again, it's the magnesium that's a vehicle for the bicarbonate to neutralize the acid. But the magnesium, on the other end of the spectrum, is a irritant laxative. It can cause diarrhea. So if you take enough of magnesium-containing products like Matalox and Mylanta, you may very well then complain of diarrhea. These products are certainly acceptable for infrequent symptoms of reflux disease. So if you're having symptoms every couple of weeks, twice a month, that's fine, as long as it resolves your symptoms. But if your symptoms are more frequent than that, you should probably have that evaluated and make some attempt to decrease the symptoms with diet, behavior, and lifestyle, assuming there are no alarm symptoms.
Oh, okay. Let's talk a little bit about you being able to care for your parents and your parents growing older. A lot of caregivers, they become a caregiver not knowing what to do and not expecting it, and it's more than what they thought it could be. How was your experience with your parents?
Probably one of the most humbling things I've ever had to deal with. Because as prepared you would think I would have been, given the fact that this is something I do and discuss on a fairly regular basis. When it hits you personally, it's a very different type of situation. You try not to get emotionally involved with patients, with their medical illnesses. That's a very different story when it comes to your parents. You try not to second guess their physicians, micromanage things. And first and foremost, for anybody out there who is a physician taking care of elderly parents, don't treat your parents. That's first and foremost. And I think most of us understand that. But just finding the proper resources, especially being, 1,200 miles away from where my parents were at the time, having to deal with the phone calls constantly and, the advice that I was very often reluctant to give because I wanted them to make sure that they were seeing their doctors on a regular basis. It's a challenge, to maneuver through that obstacle course. My first piece of advice would be take advantage of all the resources that are out there. Make sure that an elderly parent is what I'll call plugged into the system. And they probably are, and it's probably not being taken advantage of to the extent that it should be. A geriatric social worker, which you can very often find if the parent had been hospitalized at some point. There was a social worker involved in their care almost 100% of the time. They may be hospital-based, but they can certainly make a referral to an outpatient social worker. And if you can get a hold of a geriatric social worker, I would recommend that. They have a much higher level of expertise dealing with the elderly population. Having a geriatrician as a primary care physician very often is something that can be helpful. The branch of geriatric medicine now is a separate medical board. It has specific training and specific board requirements and its own exam. So these physicians are exclusively trained not only in internal medicine, but specifically how it relates to the elderly. And that can also be a game changer in bringing things to light that as a child of elderly parents, and certainly as a physician as a child of elderly parents, we're not aware of. Getting a evaluation through the social worker of home safety if they're still living at home to avoid problems, specifically falls, would be very important. Make sure that the home environment is safe, that rugs aren't loose, that they're not going to trip over thresholds, and they're not going to bang their heads if they should fall on corners of the table that may be sharp and just, make a bad situation that much worse. These are all things that are available and should be taken advantage of on an early basis, early on. Something that often is a challenge is the parents' reluctance to accept that they're getting older and that they need help. And, what does their child know? The child in their eyes is still, a teenager and, knows nothing. So throwing things at an older parent and assuming it's going to stick is usually going to be met with frustration, aggravation, and just drive a wedge between that relationship that's already being stressed and challenged. So be patient. Realize that you're not going to be able to prevent everything. But there are resources that you certainly should be taken advantage of. I tell patients who are in this situation who reach out to me because they have an elderly parent that they're struggling with. my first response is, listen, don't go about this alone. You're not recreating the wheel here. There are so many people who've done this before you. And one, there are resources there, starting with that social worker, ideally a geriatric social worker, taking advantage of local resources, knowing when that elderly parent is a danger to themselves or others, because not everybody can be managed at home. And there are different levels of environments that are available, whether it's anything from assisted living to skilled nursing facilities, and then having frank discussions with elderly patients about what their wishes are. We often start treating our elderly patients like they're our children, and that's just not right. They're not. They have unbelievable experience over time. They're usually frightened because they realize that they're getting older. They realize that they don't have the same control that they had for, the rest of their lives previous to this. They're becoming more reliant on people. And there's usually some fear associated with that. So having frank discussions with them, making sure that you understand what their wishes are medically, whether it's, advanced directives, I strongly suggest you discuss with your parents and get that in legal writing. You don't need to hire a lawyer for that. There are forms online for advanced directives. If A, B, and C should happen, I want 1, 2, and 3 done, and I don't want 4, 5, and 6 done. We used to call these do not resuscitate orders, but they're much more advanced than that now. And they're called advanced directives. Getting a healthcare proxy is extremely important. It doesn't necessarily have to be the child. It's somebody who the elderly parent trusts to make those decisions. And everybody should be on board on who that person is. But healthcare proxies and advanced directives are critical, and they will save a lot of aggravation down the line if everybody's on the same page. Listen, these are difficult discussions to have. I get it. But trust me, if you're thinking about it, your elderly parent's thinking about it too. And it is well worth that difficult discussion, because it's just going to make things less complicated down the line if everybody's on the same page. And lastly, you don't go this alone. Hopefully there's siblings involved. I had a great resource in my own children who had great relationships with both my parents, and really were incredibly supportive. My wife was incredibly supportive. Other friends and family members throughout were there for me. So don't go at this alone. Take advantage of people who are there to help you.
Okay. Thank you for that. Is there anything else medically that we should watch out for and look for as a caregiver, signs and things like that, or some kind of other illness that we need to know about?
I think we touched on the big issues with the aging process, elderly parents when it comes from a gastrointestinal standpoint. Routine screening procedures really should continue. There are guidelines and recommendations about when they should stop. Please don't be pushed into, I don't know if age discrimination is the right word, but there's a difference between chronological age and biological age. I see certainly many patients who are well into their 80s and even their 90s. Chronologically, but biologically, physically, still incredibly active and healthy, mentally and emotionally, incredibly well put together. Those patients, should continue to have those screening and preventative types of procedures, whether it's mammography, whether it's gynecological exams, whether it's urological evaluations. Skin cancer screening should certainly be something that should be continued. see many patients with figuring types of dermatological issues. Skin cancer is not the least. Only because it was, it's not important. It was neglected. That shouldn't happen. It takes away from people's self-worth. So screening procedures like that should continue based on recommendations, but also need to be modified for the individual patient. Remaining active physically and mentally, extremely important. Isolationism, if people can't get out of the house for whatever reason, depression is a big problem. They don't want to interact with, friends and family and loved ones. That's going to, people are going to age mentally much faster when that happens. So depression screening needs to be done on a regular basis by that primary care doctor. Geriatricians are phenomenal with that. And depression should be treated aggressively in this population.
Okay. Well, thank you so much. I appreciate all the information that you've given us, and I'm sure it'll help somebody. And I just know that, there's a lot of things that we just kind of take for granted we go along with, and, it's just going to happen. If we're belching, if we're doing these things, we've been doing it, it's no big deal. But, to have someone say, listen, just go check it out. Go check it out and see. So
Absolutely.
I appreciate that. So thank you so much for your time.
You're very welcome, Francine. Thanks for having me.
All right. Take care.
Yeah, thank you.